My name is David Cull. I am a vascular surgeon that's been employed with the Greenville Health System for about 18 years. Although I'm a vascular surgeon and I do all types of vascular surgery, the area of particular interest that I have in research is in the area called vascular access surgery. And those are operations that are designed so patients who are on hemodialysis can be connected to a dialysis machine. There's probably not a single operation that we do in all of surgery that has a higher complication rate. Basically, we set up these flow circuits in the arm which allow nurses to stick needles into these shunts to draw blood out, run it through the dialysis machine, and put it back into the body. And these shunts, once they're created, they run continuously. It's like having a car run in your garage 24 hours a day, even though you're only driving it a few hours a week. Almost all of the complications associated with these shunts are a result of the adverse hemodynamic effects of the continuous flow. The first device I came up with was a device called the Hemo Access Valve System. I conceived of the idea about 15 years ago. I did my own patent search originally to look for competing technologies, and then I ultimately started a company around that device. Since the development of the initial device, the Hemo Access Valve System, we've had to come up with many other modifications of that device. Multiple patents have been filed both in the United States, in Europe, and in Canada to try to enhance it over and over and establish a intellectual property fence that can't be overcome by somebody else. After establishing that company, I had another idea for a device that would make it easier for nurses to insert the needles into the shunts. I called that device a fistula finder. It was a very simple plastic device, very inexpensive. And the fistula finder was folded into CreativeVasc. And these devices are used across the United States in dialysis units. More recently, I have been involved in developing a training simulator, again, to help nurses stick fistulas. I've been working on the training simulator for about 6 months at the request of one of the large dialysis companies. There is a great need for a better simulator. There are several on the market, but none of them are very good. And then I am working on a device that will help prevent wound vac sponges from being retained in wounds. Each device has a different regulatory path, a different funding path. The Hemo Access Valve System by far has required the most collaboration. I've been lucky to have partnered with not only a brilliant businessman who was willing to give up a very high-paying job to simply build CreativeVasc Medical. I also have been fortunate to partner with very smart engineers. Actually, some of the very early engineering work was done by undergraduate students at Clemson. We have raised about $9 million to develop this device. The wound vac sponge device is a device that I've been working with my son. For that device, I'm going through the Research Development Corporation here at the Greenville Health System. That device would likely be developed through a licensing agreement ultimately. I think that the one message I would give inventors, engineers, students that are interested in going into this really important lesson is that I don't think that you can spend too much time talking with the users of the device. I think that inventors tend to think of their device, and I don't think they do the due diligence that's needed to find out exactly what is the market for this, what are the competing technologies. I mean, really dig deep. And then talking with the users. One error that I've seen over and over of inventors Frankly, this happens with the undergraduate students from Clemson that come over. They will ask a surgeon, well, what device do you need? Give me a list of 3 or 4 devices. And these surgeons might kind of throw something out. They haven't really done that much thought about it. And so when we give you 3 or 4 ideas for a device, I think there's an assumption that these are really important devices because here's an expert that uses this in this field. Well, he hasn't really done due diligence as to how important this is and what the market is. And some of these devices, he's not even the end user. It's a trap that I think we all can fall into. Psychologically, it's the most difficult part of inventing is that once you've come up with an idea, particularly an idea that you think is really revolutionary, there is almost a fear of finding out that there's something out there that is going to compete with your idea. The further you move down the path of development, the harder it is to become objective, to be objective regarding your device. So it takes a lot of courage, I think, to be able to step back and critically analyze what you have. I've been working on this hemoaccess valve system for 15 years, and I've been modifying it over and over and over again. And the device today is completely different than it was before. No matter how good the device is, no matter how valuable the device is, if there's not a business case for it, it's not likely to survive. Fistula finder is a good example of that. This is a very simple, inexpensive device. Probably costs $0.25 to make. We did some early clinical trials which showed that it decreases the complications with cannulation of fistulas. One of the problems that I would have never thought of before we started the company is that these little devices are reusable. So you have a device that costs $0.25 that can be reused 100 times. There's no business model that can be developed where that could become profitable. The hot area right now, as you mentioned, is in the area of quality and safety. I think that devices or processes that make surgery or being in the hospital safe is likely to be something that they're going to be interested in. Complications of patients in the hospital cost money. Hospitals are willing to pay for devices that save money in the long run. What they're not willing to pay for is tools that make their surgeries easier to do. Surgeons typically think of new scissors, new clamps. Those types of inventions rarely get very far because most hospitals, most ORs already have tools that do okay, and so these instruments are very expensive. So that's another example where you really can't make. Is somebody going to pay $500 to replace an instrument that's working pretty well? And it's not likely to happen.